So may I now request our star retina surgeon from West Bengal, North Bengal, Dr. DEEPAK AGARWAL. He has been awarded multiple awards, multiple publications. He was working in Disha Eye Hospital. He's been trained in Vitreo Retina services. Right now, he is working in North Bengal, Siliguri Greater Alliance Eye Hospital. Over to you, Dr. DEEPAK.
Thanks a lot for such kind words. So, my case is a case of subretinal hematoma with inferior RD, which was managed with subretinal tissue plasminogen activator and an inferior 180-degree retinectomy. So, I have no financial interest in any of the products mentioned in the case. So, case history. A 55-year-old female presented to us with severe diminution of vision in the right eye for 15 days. At presentation, her vision in the right eye was hand movement and the left eye was 6/6. Anterior segment was essentially normal except for a very early cataract. So what we see in the fundus photo is in the right eye there is a massive subretinal hematoma which is extending both above and below the arcades. Left eye is essentially appears to be normal with some amount of disc pallor in the temporal region. So let's look at the OCT. The OCT shows us what I am trying to see is subretinal hematoma, which is indicated by the yellow arrow. There is a subretinal fluid, as well as there is subretinal heme, sub-RP heme, sorry. So let's look at the case. Let me just say in the beginning that after the case presented, the patient presented for OT after 10 days. So pars plana ports were made. Now when I entered the vitreous cavity, I was surprised to see breakthrough bleeding, which was removed with core vitrectomy, followed by PVD induction, and then the completion of vitrectomy. Now I am injecting subretinal TPA with a 38 gauge subretinal needle at multiple sites. After these injections, we waited for 10 minutes for TPA to act and the clot to dissolve. A 180-degree, in the inferior part of the retina, 180-degree cautery was performed, endocautery was performed, followed by 180-degree retinectomy with cutter. The entire subretinal hematoma was drained out by the suction property of the cutter. The inferior detached retina was folded upon itself to look for the submacular pathology. And the blood which was present in the submacular part was removed with the suction property of the cutter. The detached retina was placed back with PFCL, and some endolaser was performed at the margin of the retina. Fluid gas exchange was performed. And also the removal of PFCL was done. Endolaser was completed with 360-degree endolaser was completed. And silicone oil was injected. This silicone was of 5,000 centistrokes. In the post-operative period, at 14 days post-operative visit, the vision has improved to 6/60 from hand movement. And what we see is that in the pre-operative period, the hemorrhage subretinal hematoma has gone, and even the sub-RP hematoma is resolving. Thank you very much.
Thank you so much, Dr. DEEPAK. May I now request Dr. Manoj Saswade, sir, to comment. Sir is trained from Shankar Netralaya, Chennai, and is presently founder and director of Saswade Eye Clinic and Laser Retina Clinic at AGARWAL. Sir, over to you.
Yeah, well done, Deepak.
Thank you, sir.
Let me know why you do the subretinal surgery.
Pardon, sir.
Why you opted for going for the subretinal surgery?
So in this case, the hemorrhage was very thick. It was long, 15 days has passed from the presentation, and also it was a massive subretinal hematoma. So, without subretinal surgery, it won't have helped much to the patient.
Was it a predominant subretinal or a sub-RP hematoma?
Pardon, sir?
Was it a subretinal or a sub-RP hematoma?
It was both, sir.
You just see your OCT.
Yes, sir.
The amounts are from sub-RP.
Sub-RP as well as subretinal.
And there was a breakthrough, and
Yes,
it was a old vitreous hemorrhage. Why I am saying that? What is the importance of timing in such surgeries? Is there any importance of timing in such surgeries?
So I was actually surprised because when the patient presented to us, there was no vitreous hemorrhage, but on OT table there was breakthrough vitreous hemorrhage.
But on this was an old vitreous hemorrhage. It was not a fresh red color hemorrhage. You can see that was a khaki color vitreous hemorrhage. That means itself suggests that it was a long-standing.
No, sir.
Yeah, that's the thing. And second thing that why timing is important. The answer is that
because the toxic effect of the
toxic
blood,
effect. Toxic effect of what?
The heme which is present in the
Heme, when the RBCs lies, it converts into heme and bile component. The bile is more toxic. So we want to do, and that timing is important. Already 15 days were over, and second thing, the hemorrhage itself was altered. So in cases why you did not tried the anti-VEGF in this case? What was the basic diagnosis in case?
So most likely it was PCV. So
Yes, PCV will be managed with anti-VEGFs or directly a surgery is a indication.
yes, so that can also be tried.
Yeah, that's the thing is that in nowadays we don't require a 180 degree inferior retinectomy in the presence of or availability of anti-VEGFs, in the availability of TPS, availability of SF6 gas, all this can be tried first.
Yes.
Otherwise, this surgery itself is more traumatic. This is a massive hemorrhage, subretinal as well as sub-RPA, and the surgical trauma is more than it would have been managed well without that, and you get the equally good results with this.
That can be tried in the future.
Yes, thank you very much.
Thank you, sir.